We're the Triple D team, the local team from Sandwell. We didn't have so far to travel compared to everybody else, but it was still quite cold this morning. We're a relatively new team, set up in October, and I was the first one to start. Purely because of the number of elderly patients being admitted to the trust. We're a split site trust and we have community beds as well to try and alleviate the distress for patients, and also certain use of certain drugs and using one-to-one care, which was costing quite a lot and not always being effective. So we're trying to we have a pathway that we use that's based on clinical need rather than diagnosis, so it's not specific on a diagnosis of dementia. We have a multidisciplinary team. Both Simone and I are general nurses. We have Stephen, who's from a mental health background, and David, who's from learning disability, so we can sort of cover all different angles. And it's introducing a pathway for staff to use to provide more personalised care for patients and actually try and get people back to their home environment rather than the numbers of patients that are admitted to nursing homes or the moves around the hospital. We're monitoring how many times they get moved from admission, which obviously causes increased distress, and especially with patients with delirium, that can exacerbate things, and it's trying to reduce the need for using drugs.
So our vision is keeping the patients and their carers at the heart of the service, making sure that individualised care planning is going on. So on admission, patients with dementia, delirium, distress, they're assessed by one of our team. If they have needs that we need to meet, they're commenced on the dementia, delirium and distress pathway. We are known as the outreach team, and we use Therapeutic Activity, so we have a range of people that kindly knit us twiddle muffs. I'm not sure if many of you have seen this, but we have in particular a knitting and natter group, and they knit in one of their local libraries for us, and it was a nursing team that used to work in our hospital. They've now retired and they do that for us. We have Dementia Champions. We train student nurses, healthcare assistants, other nurses and professionals within the trust to be Dementia Champions to support our patients with dementia, delirium and distress. As Annie said, we identify needs rather than diagnosis, so instead of just having a dementia pathway for needing a diagnosis of dementia, it's for anybody. The pathway can be used to fit all, really. Carer involvement, that's a big thing that we promote. So we have carer steering groups that go on within the trust. We promote John's campaign within the trust. We have beds actually allocated on the ward if carers, relatives, loved ones want to stay over. Open visiting times. We provide meals for carers who want to stay, and just to make sure they're involved with care at all times. Education, we've put on training days. We've got one coming up, haven't we?
Monday, yeah.
Training regarding dementia, delirium and distress, but also we're using digital reminiscence therapy, which is a new machine that we have. We can bring it to the wards. It's got for example, there was a gentleman that really liked horse racing who had dementia, used to go and watch the horse racing in the bookies. So we could put horse racing on for him, get him a paper so he could read what the horsing was today. So it just helps with therapeutic activity. And going back to person-centred care, so our pathway is designed, it has an All About Me document, which is a 2-page document which can be filled in by carers or relatives, or if they don't have any carers or relatives and come from, say, a nursing home, we'd liaise with the nursing home to find out what the patient's likes, dislikes, preferences. We've got ABC charts which refer back to individualised care planning. You know, for example, a patient that was previously a postman, he'd get up at 4 o'clock in the morning, so we can meet their needs, knowing that, you know, John used to be a postman, he is going to get up early, but that's a normal routine for him. Personalising the environment, encouraging carers and loved ones to bring in, you know, if they like playing dominoes, if they have photos up of their family at home, bringing them in, encouraging them to bring in photo albums. We had a patient who used to make wedding cakes for people, so the family brought in an album with all the cakes, so she was able to relate to those and tell us stories about who she'd made cakes for, and then Therapeutic Activity, which we'll discuss on another slide. I'll hand you over to Stephen.
Okay, well, I think you've covered a lot of the other slides. in terms of what,
That's the problem in our team, isn't it?
well, education, as someone once said, absolutely central to what our team does, and in terms to promote good health care. A lot of what we do, what we're doing is in terms of co-production, co-working with other stakeholders, which includes carers, it includes our colleagues in the acute trust. We do bespoke training if necessary on the ward. We do role modelling on the ward, as well as more formal workshops we're available to do as well. In terms of carers' involvement, Simone's just mentioned John's campaign. We've got information to identify carers. We've got laminated little badges and things, going to be absolutely clear who are carers on the ward. We're involved in quality improvement, service user and carer steering groups, carer support groups, and we offer carer support roadshows across clinical areas. We've got this branded logo, the DDD, with little stickers that we put in the notes, which promotes the service and gives greater clarity really to our role and what we're doing on the wards. We try and identify people at the point of admission and follow them through the process with monitoring and support. And as per NICE guidelines, we give leaflets to patients and or carers to explain the pathway. We also work to promote Dementia Champions using the University of Worcester course. Did quite a lot of work on Linden 4 ward at Sandwell Hospital. This again feeds back into the service and aids in terms of co-working with our colleagues. And in terms of the multidisciplinary nature of the group, we're following really implementing things like the 5-year forward plan in terms of things like mental health, learning disability. We are promoting parity of esteem in that sense between the different professional groups, and hardwiring mental health and learning disability into physical care.
Right. Last but not least, right? Yeah, we find that therapeutic activities really work. You've heard about earlier about people who were postmen, cake decorators, etc. So often they've got remnants of those skills left. Now we have a fabulous therapy coordinator, Donna. Bless her, she couldn't be here today. Fortunately, somebody's got to run the service. But basically, she does a fantastic job. She does art therapy, touch therapy. I'm sure there's not a therapy that she doesn't at least dabble in and try, and does very successfully. We've got specialist HCAs who provide one-to-one care. They also provide therapeutic activities as well and support her. I know some of her volunteers are particularly good. So, the clinical team, what do we do? To start off with, we provide holistic assessments, and we promote the patient-centred care through role modelling. I will go onto a ward and I will show staff how to speak to somebody with learning disabilities. I'll find out what's the best way of communicating with this person. Now, I'm sure we can all read a book and think, oh, talk to a person with learning disabilities this way. But with my experience, I will find out the best way for them, and then I will put it in the All About Me document. We will also try and reduce one-to-one care, because before we were here, the focused one-to-one care, that they seem to use them a lot. So we brought in strategies to say, well, rather than having a carer here, let's reduce the beds.
Based on risk, yeah.
So we've looked at the risks. We also, with our knowledge as well, help people understand the Mental Capacity Act and the DOLS. So we've very much helped people with capacity or partial capacities still to make the decisions that they can. So we've also hoped to try and remove the amount of moves that people do from ward to ward to ward. Now, and last but not least, this is my major part, to reduce the distress in clinical areas. So, what every manager is interested in is the outcomes. They'll say, cut to the chase, what does it do for us? So within the first 3 months, the amount of bank and agency booked for the one-to-one focused care was reduced by 60%. We reduced falls, we reduced the amount of admissions to 24-hour care, we reduced the incidence of violence and aggression, reduced the number of complaints, increased care involvement, and increased even collaboration working between acute and community teams. I think I'm getting a nod here to say, please, any questions?
Absolutely perfect.